On this episode of the Ask Mike Reinold Show, we talk about progressing post-operative patients. We talk about academic versus clinical-based PTs and what to do with your programming with former overhead athletes.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Welcome back, everyone, to the latest episode of the Ask Mike Reinold Show. I'm here at Champion PT and Performance up in Boston with Lenny Macrina, Dave Tilley. We're here to answer some of your awesome questions, your PT questions, your fitness questions, your sports performance questions, your business, baseball, gymnastics, sometimes life questions. Lenny can answer some life questions for you.
Dr. Phil.
Right. I can teach you how to use Trello and Evernote really easy. Ask us away. Keep asking. You guys are doing a great job submitting some great questions. You can go to MikeReinold.com and click on the podcast link and submit some more questions. We get so many good ones. We really appreciate it. All the comments are great. We read them all. They're fantastic. So we'll try to get to as many as we can on each episode here. So definitely keep submitting, and it's my turn. I'll read away on this one. So let's see. We have first question is Savannah from Florida. Hi! Exclamation point. For ACL rehab, do you rehab based on a time protocol or how the patient is progressing? I'm a DPT student and I've been at 2 clinics where they progress fairly differently. Len, you want to start this one?
Yeah. I mean, protocols, as a new grad or a DPT student, you can use the protocol as a rough guide to kind of help your mind think, if that makes sense, because the protocols have been set up, especially the ones that we developed when we were in Birmingham with Kevin Wilk and Dr. Andrews, were based off of healing and research of patella tendon healing and just wound healing and just natural healing. So you can use those as a rough guideline, and then keeping that in the back of my head, this is my approach. I take that approach or take that information and then I base it off of how the person is presenting. Do they have any concomitant issues, meaning do they have meniscal involvement? Do they have a bone bruise, which a lot of them do? Do they have any articular cartilage issues, any MCL sprains, any other things going on? And then I have to formulate a plan based off of that as well. So my answer is kind of both.
Right. Because you're good and you've been doing this for a while and you've seen so many different surgeries and stuff. I mean, I always consider a protocol. So the protocol is like the fastest you can go. You can't go faster than the protocol, right? Because the protocol has been designed based on, like Lenny said, the basic science and our understanding of the tissue that's involved and the healing response to that specific surgery that you just had or they just had, right? So oftentimes it's like you can't do this because we're trying to protect that tissue. So a protocol is like the fastest you can go. And you want to try to hit the guidelines in a protocol so that way they don't get behind.
Right.
I think that's the way to do it, but that doesn't mean everybody's always ready. So a good example is when you get to the advanced levels and the return to activities and stuff, everyone's like, so for like baseball, it's like, when do you start throwing a ball? It's like, well, it's not week 16. I mean, yes, that's the earliest you can throw, and oftentimes if you've nailed everything, you're good, but you have to have a good clinical exam. Like you have to have done the right rehab progression. Like if you haven't done 2-hand plyometrics, you can't go to 1-hand plyometrics. If you haven't done 1-hand plyometrics, you can't start throwing. Just as an example, just using that, like you wouldn't go right to like, all right, you can play basketball because it's month 6 after ACL. Well, like, no, you haven't done cutting, you haven't done running, you haven't done jumping drills, those types of things. So the protocols is the fastest you can go, and you should try to be close to that, but sometimes people are a little slower and they have to meet the guidelines. So you don't just do something because it's week X, you do it because they're ready for it.
And you got to think about the end plan. Like when does, your example, it's an ACL, we do a lot of baseball here. When do they need to be ready to be game ready? So then you got to build backwards from that. So we have 9 months in theory, and there's always going to be a hiccup. When you hit somewhere in the process, you're going to get delayed. But if we have 9 months, then I want maybe to have them cutting at 7 or 8 months in theory, and I want them running at 5 to 6 months, and I want range of motion, and you got to build oftentimes backwards from the ultimate goal, because I think that'll at least give the patient or the client something in their head, a goal to shoot for. And also it kind of you build off of that as well. Did I say that correctly? my mumbling.
That was good.
No,
No, that was good.
It's gotta be both, and I think your point of like when they need to be ready is really important. So, for example, we had a younger female who's going to college, and she didn't need to be playing right away.
Right.
It's like, why
Correct.
not take the extra
Right.
2 months? And I think we're seeing in some of the research, especially from BJSM, is like every month extra was another 20-something% that they were at less risk to re-injuries, because
Right.
you have to work on the advanced strength, and we're seeing maybe the protocols that were developed are
Right.
good for this, but maybe not that like very high level sport when you
Right.
be a little bit longer.
And we're learning longer is better. Yes, absolutely.
So,
Yeah, probably. Yeah, makes sense. Awesome. All right. Next question. Casey from Charlotte. Hi, Mike and the crew. I'm a big fan of the show. Thank you. You guys get a T-shirt that says crew. I'm a big fan of the show. I'm currently a first-year master's student and CSCS, and I'm still not sure about which career path to take after graduation, either a PhD or a DPT. I love working in the lab on research projects, but I also love working with clients and patients in the clinic. Do you have any recommendations regarding bridging the gap between the lab and the clinic, and would you hire a rehab biomechanics PhD to work at your facility? Well, I would. I don't think we could afford you. Yeah, no, that would be cool. So, all right, so PhD versus DPT. Anybody
Again, I think this comes down to the where you want to go with your career, right?
Correct.
So again, DPT,
Right.
clinical, with people, orchestrating the rehab process. I think PhD is probably going to take you more the scientific route to be, you're going to get a PhD in more advanced
Academic.
biomechanics. Or,
Yeah.
Right. So I think that really comes down to what you want to do with the majority of your career.
Right.
I do know some friends of mine that went on and want to be like half lab, half clinical, and they do both.
Right.
But I would just say it's challenging to be really good at both, to master all of the heavy stuff in the academics, but also be really up to date and current with the literature in DPT.
Right.
So
Yeah.
Right.
I worry that you're kind of like dipping your hand a little bit in both too much. But that's just my personal opinion.
It's almost like academic versus clinical, right? Like it's, I think it'd be super weird. Well, it probably wouldn't be super weird. I shouldn't have said that. But like, getting your PhD and then working in an outpatient PT clinic seems like it wasn't worth your time, to do that.
But then using somehow your PhD background, even if you don't pursue it all the way, and being a clinical researcher and publishing stuff based off of your experiences as a PT,
Right.
That's valuable stuff,
for sure.
because you're in the trenches every day, you're living it, and you're sharing your information with statistical analysis and everything else. I think that's so powerful stuff that we've done when we were at ASMI. And I think it's huge, and it kind of gives you a little more credibility too. I think for the profession that you're living it every day and you're seeing it happen. So
Well, I'm curious about that, because when you guys were doing a lot of your research, were you still actively treating?
oh yeah,
Oh my God, we're doing it
weekends with
6,
paper
7, 8
That's a
o'clock
ton
at
to
night.
take on, but that gives you guys a lot of.
Well, so do you want to do academic and lab-based research, or you want to do clinical research?
Right.
And that's so
True.
we do not have PhDs, and we do a ton of clinical research. We still do clinical research, so it's different. And I think there needs to be both.
But we worked with PhDs who helped us build
Minimally, but
Fleissig
it's
and
different.
ASMI was huge, and for statistical analysis, easy for me to say, statistics.
Just stop.
It's
Just
the
stop.
analysis of what we've done, and then we did the clinical implications, we did the introduction, and they helped with the results, and then
the design versus
design of
actually
it,
doing
yeah.
it. So
It'd be hard to do
different.
yourself.
It's
all of
different.
that.
I mean,
Right.
it wouldn't be fun to do all that yourself. I mean, that's why you collaborate. But I mean, if you go to a big meeting, you go to APTA or something like that, you go to the sports section's team concept thing, you could tell who the academic people and who the clinical people are. You can tell. When somebody says, I'm a professor at a university, and then somebody says I own a practice, their presentations are different.
Right.
So you get the one that's all research based, but not a lot of clinical implications, and then you got the clinical side, which is a ton more clinical implications. So I think we got to work together, but they're definitely different.
Yeah.
So I don't know. I think we do a good job blending the clinical research in. So I mean, if you truly love seeing people, I wouldn't say you need a PhD to do research,
Right.
but I don't know. I mean, you definitely got to figure out where you'd rather be. What do you want your primary job to be? I know there's plenty of PhDs at universities that treat people like in the school's clinic or something like that, like once or twice a week, those types of things. But that's clearly not saying I'm the clinical guy. Like, just treating somebody once a week's not.
Right.
It's just different. It's
Right.
different. So, all right, let's see. Last question. Vin from New Jersey says, how would you adjust a program for a former overhead athlete that's trying to correct asymmetries as opposed to a current thrower trying to avoid creating them?
Oof.
Okay, so let's say
that one.
an ex overhead athlete is trying to correct their asymmetries.
I guess it's
Bad news?
probably going to be bad news. Those asymmetries developed when you were very young and probably through middle school, high school, and maybe college, depending on your life. They are there, and they're probably not going away anytime quickly. They're probably bony, a lot of them, at least in the shoulder if you are an overhead athlete. So that definitely you have to break your humerus and have it reset to correct some of that stuff. Probably not going to happen. So, there might be other things that you can, lower extremity, pelvic type stuff. But even then,
I bet you that's bony too.
Yeah, it's probably bony. So
Yeah.
I think it is what it is, and I think it's why you're trying to correct the asymmetry. What is it doing? What is it affecting? If you're like, I can't scratch my back, my right side, but I can do it on my left. Well, just scratch with your left. There's no need to.
They sell those scratch things.
And stuff like that. You're always pointing stuff out to people that asymmetries are very natural and normal, and nobody is symmetrical.
Right.
Yeah, the asymmetry in these overhead population probably isn't something you can address soft tissue. It's not loose versus tight or strong versus weak. Now, you might have some of that, but those are easy to address, and I don't think you're having trouble with that. I don't think that's where this question is. It's more the other things, and unfortunately, those asymmetries are probably there to stay.
Yeah, I would say, as we've talked
I still
on,
got it.
I do not.
I still got it.
My 59
I
miles
still
per
got
hour
it.
shows it.
I got it. Wow, I look terrible.
Can we just
I'm
put
looking
this
at
as
my
the-
Yeah, are we doing a dance?
Looking something tells me that's going to be this week's image.
I would say, obviously, it's like, what do you want to do with your fitness or your life? Like, do you need to be doing bilateral barbell exercises when you could do asymmetrical stuff and not?
But I want to, Dave.
Well, it comes down to what you're willing to sacrifice for it then.
Yeah.
If you're willing to put up with some shoulder crankiness to get to whatever.
Right.
But again,
Awesome.
whatever your goal is.
Awesome. Well, thank you guys. Another great round of questions. We appreciate it. Keep asking away. Go to MikeReinold.com, click on the podcast link, and you can submit your own questions. Again, anything you guys want to talk about, not anything, but stick to what we do. Stick to what we do.
Direct
best.
message Lane.
I'll give you a cell phone. Just email it. But ask us some questions, and be sure to sign up for our email list so you can get notifications when we have some new content on there. A bunch of cool little freebies you get with that too. And go to iTunes, leave us a review and a rating, and we'll see you guys on the next episode. Thanks
Bye,
again
guys.
so much.
See ya.
Gymnast.